Okay, the next joint exam that we're going to do is the knee, and we'll start again with inspection, and then palpation, and then range of motion, and then specific testing of different structures. So the first thing we want to look at with the knee exam is inspection, and you want to look for swelling. So the first thing that I have them do is tighten up their quadricep muscle, and you'll notice that there is a divot here and a divot here. If they have a joint effusion, that divot will fill with fluid. If it's fluid in the bursa sac, the fluid will actually sit here on top of the kneecap, and you'll still have your divots. And if you squeeze the skin, that will hurt the bursa sac. So once we've seen where the swelling might be, the next thing that we want to do is have them do active range of motion. So we have them extend the knee fully, and she can actually hyperextend her ankle a little bit. That's knee recurvatum. And then we have them flex the knee as far forward as they can with the heel slide, always comparing it to the other extremity. Once we have range of motion, the next thing we want to do is identify the structures that may hurt through palpation. And I normally start with the patella and the structures around the patella. So first you have your quadriceps tendon, and I'll usually have them tighten up their knee and palpate across the quadriceps insertion onto the patella. Then I'll go to the bottom of the patella and push on the patellar tendon origin on the patella, and then follow it down to the insertion on the tibial tuberosity, where you develop Osgood-Schlatters disease in a kid. If you have pain at the distal patella on an adolescent or a child, that is Sinding-Larsen-Johansson syndrome. Once you've palpated along the patellar tendon and identified possible Osgood-Schlatter or Sinding-Larsen-Johansson disease, then you want to palpate along the medial and lateral patella. Palpating along the medial patella, you have the medial retinacula, which attaches the patella to the distal medial femur for stability. You can have what's called a medial plica band, which is a band of tissue, feel like a bowstring when you rub your fingers back and forth. Then you can feel for tenderness along the lateral patella. You can move the patella medially and laterally and feel underneath the patella to see if there's sore underneath, where you might get pain with patellofemoral syndrome. Then you can go down to the area of the proximal tibia, where you have the pes anserine bursa, and palpate there. Oftentimes they'll get local swelling there when they have pes anserine bursitis, and that's the attachment of the crow's foot for the gracilis, sartorius, and semitendinosus tendons. Next, I usually bend their knee to 90 degrees, and then you can feel the joint line. And I'll start to feel the medial joint line for tenderness, either from arthritis or a meniscal tear, or the lateral joint line. And oftentimes, if you have a hard time identifying where the joint line is in a very large patient, you can at least find the fibula, and when you find the proximal fibula, then you can find the joint line just above it. Now you can also palpate the hamstrings in the back, which is hard to show in this video, but the semitendinosus, or the biceps femoris, is attaching to the fibula, and the semimembranosus and tendinosus are on the medial aspect. And usually when they tighten up their hamstrings, you can identify those structures and see if they're sore. Once we've done observation, range of motion, palpation, then we move to specific testing of different parts of the knee. Usually, again, I'll start with the kneecap, and I'll start doing some tests for patellofemoral syndrome. The first one is Clark's sign, where you hold the proximal patella down with some force, but not a lot of force. If you hold it too hard, you'll hurt anybody. So you hold it with just a little bit of force, then you ask them to fire their quad muscles, and you just give them some resistance down on the patella. And then I usually have them do that twice. The ones that have bad patellofemoral syndrome will know that that's going to hurt, and they'll be very apprehensive or tentative, whereas those that it really doesn't bother will just fire right through your fingers. The next test is the lateral apprehension test, where you put your fingers medially on the patella and you push laterally as hard as you can. And if the patient has had a patellar subluxation or dislocation, the patella usually goes laterally, and that will cause the chandelier sign. Well, they'll jump off the table, or that'll really bother them. The next structures that we want to palpate, or next structures that we want to test is the meniscus, which sits in the joint line. And there's several ways to do this. One is the McMurray's test. And then for that test, I'll usually put my fingers on the joint line in a C-shaped fashion, and then cup the heel with my other hand, and then just flex them, flex the knee, and then internally and externally rotate the tibia. Then extend the knee and doing the same thing, and then kind of do it as one big motion. And if they say that that causes joint line pain where my fingers are, then that can tell you which meniscus may have been injured. The next structure that you want to test is the anterior cruciate ligament, which keeps the tibia from translating forward. You do that by doing the Lockman exam. You want to put your top hand across the femur and the quad muscle, and the bottom hand across the tibia, oftentimes your finger near the tibial tuberosity. And then the most important thing is getting them to relax their quadricep muscles and their hip flexors while you're doing this. Then you have to raise them to about 15 degrees to 30 degrees of knee flexion with your top hand, making them comfortable that you're not going to drop their knee. Then with some downward pressure with the top hand and some upward pressure with the bottom hand, you want to stress that ligament. And you should feel a nice snap when that ligament becomes taut. If you have a soft end point or it's a lot looser than the opposite side, then that is indicative of an anterior cruciate ligament tear. Next, I'll usually bend the knee again to 90 degrees and feel for a posterior cruciate ligament tear. And oftentimes on that, if you just put your fingers right down on top of the tibia, you should hit the top of the tibia. If your fingers do not hit the top of the tibia and go straight down the tibia, then the tibia is sitting backwards, indicative of a posterior cruciate ligament tear, and that's called a sag sign because the tibia is sitting backwards. The other way to test that is to sit on their foot, put your thumbs on the top of the tibia on the joint line, put your palms of your hands on the tibia, and push backwards. And that should not move backwards, but a couple of millimeters at the most. Again, always comparing to the opposite uninjured knee. And that's a posterior drawer for posterior cruciate ligament stability. Next, another way to test for the ACL is the pivot shift test. With that test, you want to put your hand, your top hand on the lateral joint line, your bottom hand cupping the heel, and you want to flex the knee while applying a valgus stress medially to the knee. And what you'll feel is a thunk as the tibia subluxes and reduces back and forth at the knee. That's probably the most difficult portion of the knee exam, is to get a good pivot shift down. The next thing that we want to test is the medial collateral ligament. That extends from just above the joint line on the distal femur to below the joint line on the proximal tibia. And the best way to test that is to do an exam somewhat like a pivot shift, but you cup the heel underneath your hand and put it up in your armpit. Then you put your hand on their calf. You put your top hand on the lateral joint line, and you keep their knee fully extended, and you apply a valgus stress across the knee joint without rotating the hip. With the knee extended, the joint should never open. If it opens, that means not only do you have an MCL injury, but you also have an ACL or a PCL injury. Next, you just want to bend the knee 15 to 30 degrees and do the exact same valgus stress to the MCL without rotating the hip. And on this, the easiest thing is to feel not so much the opening of the joint, but the closing of the joint as it returns to neutral. Again, comparing it to the opposite knee. To test for the lateral collateral ligament, which extends from the distal femur to the proximal fibula. You do the exact same exam as you did on the medial MCL, but you put the foot into your opposite armpit and you put your hand on the medial joint line, applying a varus force. Again, first with it extended, and the joint should never open in extended position unless you've injured not only the LCL but also the ACL or the PCL. And then again with the knee bent about 30 degrees, making sure that the patient is comfortable, that you're not going to drop their knee, and then applying a varus force without rotating the hip to the knee joint. And again, it's easier to feel the closing than the opening of the joint. Once you've tested all the major ligaments, another good test to do at this point of the exam is the hyperextension test of the knee, where you just bend the knee and then somewhat in a surprising fashion you let go and let the knee fall into the extended position. This exam is very good for testing what's called fat pad impingement syndrome. The fat pad sits right behind the patellar tendon, and oftentimes they'll get anterior knee pain when that fat pad gets pinched in the joint line, similar to biting your cheek while you're chewing your food. Once we finish examining all the structures individually, and we finish with the ligament exam, the last thing that we do is test for strength. So normally we'll have them bend their knee to 90 degrees and pull their heel to their buttock, testing for hamstring strength. And then we'll have them push forward against resistance from the hand to test quadriceps strength. And that really is all of the strength testing for the knee. Okay, for the knee exam, the last part of the knee exam that we often do once we get the person off the table is to put them in the middle of the room and have them do some different maneuvers to look for specifically meniscal pathology. And the first one we do is called the Thessaly test. And basically you have the patient get their balance and stand on one leg, and then bend their knee about 30 degrees, and then internally and externally rotate their tibia by rotating. And you see if that reproduces their pain along the joint line. And if it's a person who has bad balance, you can grab their arms and just rotate them like you're dancing with them. The next test that we often do is just have the patient duck walk and see if it reproduces their pain along the joint line of their knee. And then usually when they're down and they start to have pain while duck walking, we'll have them put their finger in the one spot that hurts to see if the pain that they're actually having is really on their joint line where their meniscus is. And that would pretty much conclude the exam of the knee that's not done on the table.